Okay, perfect. So we'll get started. So I'm Talha Allam. I'm one of the Neuroradiology fellows here. We'll be talking about the skull base and the skull base foramina today. Just a brief overview. So we'll spend the first couple minutes reviewing some normal anatomy of the skull base, and then we'll spend the rest of the time examining about 10 cases. These are cases that I have collected during my fellowship here and my residency at St. Louis University. We'll be looking at cases, of the anterior skull base, and then the central skull base, and finally the posterior skull base. And the focus here will be on anatomy. We'll also talk about pathology, but anatomy will be the main focus. By the end of this talk, you guys should be able to name and identify the major skull base foramina. You should know the course of the nerves and vessels that traverse these foramina. You should also be familiar with spaces like the cavernous sinuses, Meckel's cave, and pterygopalatine fossa, which are important paths for cranial nerves. And you should also recognize some common pathology involving the skull base. So why learn about the skull base? Well, it's a common location for pathology. It's the highway for disease between the intracranial compartment and the deep face and neck. So diseases that begin in the intracranial compartment can spread to the neck through these foramina and vice versa. And perhaps most importantly for you guys, this is a very high yield topic for the board exams. And I can tell from firsthand experience, since I took the first ABR core exam, that they do ask questions on anatomy of the skull base. So let's start out just looking at the skull base from top to bottom. These are the foramina that you see. Starting from the anterior skull base, we see the olfactory foramina. We have the optic canal, which houses the optic nerve. We have the superior orbital fissure, which houses several nerves. We have the foramen rotundum behind that. Then we have the foramen ovale and the foramen spinosum in close proximity to each other. We have the foramen lacerum, which carries the internal carotid artery. We have the internal auditory canal. Then we have the jugular foramen, and finally the last foramen, if you will, is the hypoglossal canal. So these are the foramen we'll be reviewing today in our cases. Now, the skull base is composed of several different bones. The anterior skull base is comprised of the frontal bone and the ethmoid bone primarily, but also by the lesser wing of the sphenoid bone. The sphenoid bone is the flagship bone of the central skull base, and it's comprised of a lesser wing and a greater wing. The temporal bones are part of the central skull base and the posterior skull base, and then the occipital bone is the flagship bone of the posterior skull base. Now remember that all these bones ossify by enchondral ossification, which means that these bones are formed within cartilage, and that gives rise to the foramina within these bones. All right, so let's move to our first case now. And I'll be talking through these cases. Since I have many cases to go through, we won't do the audience response here, but I'll be talking through these cases, and we'll keep you engaged here. So the first case is a relatively straightforward case. This is a 50-year-old woman who presented with anosmia, or loss of smell sensation. Here are her CT images. So what first grabs your attention probably is that there's a large amount of vasogenic edema in both frontal lobes. And what's causing this? Well, there's a mass here in the anterior skull base. And the mass straddles the anterior cerebral falx on both sides, indicating that this is an extra-axial mass. Now, why did this patient present with anosmia? Well, there are a couple structures here that are likely involved by the mass, and these are the olfactory grooves of the cribriform plate of the ethmoid bone, and these are likely involved by the mass. Now, in between here, just an anatomic point, we have the crista galli, which in Latin means the crest of the rooster, and that separates the two olfactory grooves and the olfactory nerves on both sides. So let's look at this on MR. So these are T1 post-contrast images showing the mass in various planes. And you can see that this mass uniformly enhances. And it has somewhat of a spoke wheel appearance of enhancement as well. Now the sagittal view is helpful here because it shows us a couple anatomic details here. So the mass seems to be arising from the cribriform plate of the ethmoid bone. And posteriorly, we see this dural tail which extends to the planum sphenoidale, or the lesser wing of the sphenoid bone. If we look at this on other sequences, on a T2 weighted sequence, we can see that there is a cleft of CSF surrounding this mass, again consistent with an extraaxial lesion. And this lesion is dark on T2 and restricts diffusion, indicative of hypercellularity. And this was a plain old meningioma, grade 1 meningioma of the olfactory group. So this is a relatively somewhat common lesion that we see. All right, so we've reviewed the portions of the anterior skull base, the cribriform plate, the crista galli in the center. The lesser wing of the sphenoid forms a portion of the anterior skull base as well. And the planum sphenoidale of the lesser wing of the sphenoid bone. In the next couple of cases, we'll be looking at these structures here, the optic nerve and the supraorbital foramen and the nerves that traverse those foramen. All right, so case 2 is a 35-year-old woman presenting with double vision. Here are a couple of MR images, T1 post-contrast. I want you to focus on the image on the left here first. We see this abnormal enhancement in the right orbital apex. And, well, what could this be? So when we think of orbital lesions, we can categorize them into a couple of differentials. The differential diagnosis for lesions involving any space of the orbit should include metastasis, lymphoma, sarcoid, pseudotumor, and in a pediatric patient, rhabdomyosarcoma. When we see lesions surrounding or involving the optic nerve, there are a couple other things that we consider: glioma, meningioma, optic neuritis. But this case is a little more interesting in that we have this enhancement extending posteriorly along the right cavernous sinus. And if you look at the other image, we see this enhancement, somewhat linear enhancement, extending to the right interpeduncular cistern and the perimesencephalic cistern. So let's look at this lesion a little bit closely on a coronal sequence here, and I'm going to scroll through this, and I will point out the abnormal enhancement. So in the right orbital apex, we begin to see this abnormal enhancement, which is asymmetric, and we see the optic nerve right there. So if we go back, again, I've pointed out this abnormal enhancement here on the right, and you can see lack of enhancement on the normal left side. So if we scroll back, we begin to see that on the left side, the normal side, we have this non-enhancing round structure, and we can follow that posteriorly. So a non-enhancing round structure, and on the abnormal side, this structure is enhancing. And this is presumably a cranial nerve, since we are in the cavernous sinus. So this image is a nice image because it depicts the anatomy of the cavernous sinus very well. We have the internal carotid arteries, we have the optic nerves up above, and then we have nerves within the cavernous sinus, one of which we're seeing quite prominently here on the normal side and then enhancing on the abnormal side. And as we go back, we can see that this enhancement actually extends posteriorly beyond the cavernous sinus. And we begin to see it here in the region of the interpeduncular cistern. So here's a question. So which nerve is abnormal in this case? Is it V1? Is it V2? Is it the oculomotor nerve, cranial nerve 4, or 6? So let's take a closer look at the cavernous sinus here and look at the nerves that go through it. So the cavernous sinus is basically a collection of venous channels. Within the cavernous sinus, we have the ICA, and then we have a bunch of nerves within the lateral wall of the cavernous sinus. Starting from the top, we have cranial nerve 3, we have cranial nerve 4 below that, and then we have V1 and V2 lower down, all embedded within the lateral wall of the cavernous sinus. Within the cavernous sinus, there's just one nerve that travels, and that's cranial nerve 6. Now let's, and cranial nerve 2 is up above here. Now let's compare that to our case here, and this was the image I stopped on earlier. And this image is very similar to the cartoon image here, in that you can see the internal carotid arteries here. This is the cavernous segment of the carotid artery. That's the terminal segment. We have cranial nerve 2, the optic nerve up above here, the pituitary gland, and the sphenoid sinuses. So now if you compare this image to the cartoon, you can see that this nerve is the highest or the most superior nerve within the cavernous sinus. And so the correct answer here is cranial nerve 3. So on the right side, we have abnormal enhancement of cranial nerve 3. Now, which hole does the oculomotor nerve enter the orbit, shown in this image here? Is it the supraorbital foramen, the infraorbital foramen, the supraorbital fissure, or the inferior orbital fissure? Well, the first two choices are distractors here. The supraorbital and infraorbital foramen are actually located outside the orbit, in the forehead and in the cheek, and they contain smaller branches of the trigeminal nerve that provide sensation to the face. The superior orbital fissure is the fissure that carries cranial nerve 3, in addition to other nerves that we will see later on. Now, this patient was actually discharged home, and she was lost to follow-up. She came back 6 months later with worsening diplopia. And now we can see that the enhancement along that nerve, along cranial nerve 3, has increased, and now we have nodular enhancement in the interpeduncular cistern. Now, this was biopsied, and this came back as B-cell lymphoma. So this was a lymphoma that started in the orbit and extended posteriorly, spreading in a perineural fashion along cranial nerve 3. All right, so let's move on to our next case. This also involves the anterior skull base. So this was a 24-year-old woman that was assaulted. This is a case that I had during my residency, and it's one of my favorite cases. So I believe this was a domestic kind of argument that came to this. So she presented like this to our ER. She underwent a CT scan. And you can see this kitchen knife goes all the way back into the intracranial compartment. It passes through the orbit. So which hole does the knife go through? Is it going through the optic canal? Is it going through the supraorbital fissure? Is it going through the infraorbital fissure or the foramen rotundum? So let's look at this case again in the coronal. I'm going to scroll through some coronal images here. And you can see that knife entering the orbit. And it fractures the inferior wall of the orbit right there. And this is the key image here that I want you to remember. And you can compare to the contralateral side and see which fissure or foramen this is, and that's where the knife is going through. And we begin to see the optic canals here up above and medially. And the knife passes along the cavernous sinus, along the sella, lateral to the sella. And I'll scroll through. All right, so let's take a moment here and review the anatomy of the holes at the back of the orbit, so we can answer our question. So this is a graphic showing. This is a graphic showing a right orbit, and we can see that again it's comprised of several different bones. I'm not going to go into that now, but we see these three different holes. So the optic canal is superior and medial. Lateral to that we have the supraorbital fissure, and inferiorly we have the infraorbital fissure. Now if you look at our images here, these are some selected images from our case, anterior and posterior. We can see that the optic canal is here, medial and superior, and the knife does not seem to be traversing the optic canals. The supraorbital fissure is actually this structure here, and the knife is predominantly located within the supraorbital fissure. Inferior to that, we have the inferior orbital fissure. That would be somewhere in this region. And then I wanted to point out the foramen rotundum, which connects to the infraorbital fissure, is also located here. You see this round structure. And so the answer to this question is the knife goes through the superior orbital fissure in this case. Now, which of these structures does not traverse the supraorbital fissure? And the correct answer is V2. So through the supraorbital fissure, we have V1, we have V3, or cranial nerve 3, cranial nerve 4, 6, and the supraophthalmic vein. V2 is the only one here that does not traverse the supraorbital fissure. It in fact goes through the infraorbital fissure. Okay. All right. So now this patient went on to get a CT angiogram because the knife goes very close to the internal carotid artery, so we want to have a look at the ICA and see if there's any vascular injury. So I've shown a couple images here. On the image on the right, we see the lacerum segment of the internal carotid artery on the left, and you can see it's well opacified. Just want to point out this is the foramen lacerum, which is distal to the petrous bone, and it's a short segment. The segment shown here is the cavernous segment of the internal carotid artery, and you can see that the knife travels very close to the cavernous segment right there. So this patient went on to get a conventional angiogram to further evaluate if there was any injury to the ICA. All right, and right there, I'm going to stop. Very close. So this knife barely just missed the ICA. And the cavernous segment of the ICA, that is. All right? So since we talked about the internal carotid artery and its segments, let's take a brief moment to review the segments of the internal carotid artery within the central skull base. The cervical segment is not shown here, but within the skull base we have the petrous segment, which travels through the petrous portion of the temporal bone. We have the lacerum segment, which is a short segment at the foramen lacerum. The cavernous segment comprises of two genus, an anterior genu and a posterior genu. The clinoid segment is at the anterior clinoid process. The ophthalmic segment is where the ophthalmic artery comes out. And then finally, the communicating segment contains the posterior communicating artery and the terminal branches of the internal carotid artery. So in this case, the knife is very close to the cavernous segment. All right, so far, we've reviewed the anterior skull base. We've looked at the optic canal. We've looked at the supraorbital fissure. We've looked at the foramen lacerum. So let's move on now and look at some more foramina in the central skull base. So this was a 48-year-old woman with left cheek numbness. So here's the first image, a coronal image through the face. And you'll note that we have this lesion here along the inferior orbital floor. Now, here are some reconstructions, a sagittal and an axial. On the sagittal, you can see that this lesion extends linearly, posteriorly. And this is along the course of the infraorbital nerve. Okay, so the infraorbital nerve travels just below the superior wall of the maxillary sinus, and we see this thickening of that nerve as it extends posteriorly. Now, I want you to pay attention to this region here that I have circled and compare it to the contralateral side. So this is the pterygopalatine fossa, and you can see that on the left side, the pterygopalatine fossa is enlarged, and there's soft tissue density within. On the normal side, there's fat density, which is the way it should be. And so the absence of fat or the effacement of fat in the pterygopalatine fossa indicates that this lesion extends to the pterygopalatine fossa, and we can see it here also on the sagittal image. Now, the pterygopalatine fossa is known as the crossroads of the face because we have nerves and vessels traversing it, and for residents, it's complicated to understand, what goes through it and what comes out of it. So let's take a moment to review the pterygopalatine fossa. Here's a question: which of the following does not traverse the pterygopalatine fossa? Is it the V2, V3, the Vidian nerve, the palatine nerve, or the IMAX, the internal maxillary artery? So here's a cartoon of the pterygopalatine fossa. We have the maxillary sinus here, and this is the pterygopalatine fossa here. There are several structures going in it. The pterygopalatine ganglion is housed within the fossa. So let's think of the pterygopalatine fossa as a black box or a blue box, and look at the structures here. So V2, the maxillary division of the trigeminal nerve, traverses along the superior aspect of the pterygopalatine fossa, and it goes through and through, and that is this nerve here. It goes through the foramen rotundum, and it comes out from the inferior orbital fissure. The Vidian nerve goes through the Vidian canal here and enters the pterygopalatine fossa to join the pterygopalatine ganglion. And then inferiorly, we have the palatine nerves, the lesser and greater palatine nerves that traverse the pterygopalatine canal and extend inferiorly to the palate. So these are the major nerves that go through the pterygopalatine fossa. How about this vessel here? So this is the internal maxillary artery that comes in laterally through the pterygomaxillary fissure and enters the pterygopalatine fossa. Let's look at this on an axial CT scan. This is a normal scan here highlighting the pterygopalatine fossa. So at the superior aspect, we have the inferior orbital foramen and the foramen rotundum through which V2 passes. We have the Vidian canal more inferiorly and medially through which the Vidian nerve passes. And then lower down, we have the pterygopalatine canal carrying the greater palatine nerve. Now, laterally, on the lateral aspect of the pterygopalatine fossa, we have the pterygomaxillary fissure, which contains the imax. And then medially, I didn't point this out earlier, but medially we have the sphenopalatine foramen, which opens up into the nasal cavity. And this, by the way, is the location where JNAs typically arise. All right, so if you go back to our question, which of the following does not traverse the pterygopalatine fossa? The right answer here is V3. V3 does not enter the pterygopalatine fossa. All other structures listed here do. All right, now here's a coronal slice through this patient's central skull base. And this is an important image because this can show up on your exams. I want to point out some of the important structures here. The optic nerve, or the optic canal, is here superiorly. And we have the foramen rotundum and the Vidian canal. Note the relationship of the foramen rotundum and the Vidian canal. The Vidian canal is more medial and more inferior. Now, if we look at the foramen rotundum here, we can see that it might be a little bit enlarged compared to the right side. And that wall there might be thinned out. Now, that raises the possibility of this lesion actually extending back all the way into the foramen rotundum. Well, how do we evaluate that? So we'll have to look at an MRI to see if this lesion extends posteriorly. So here are coronal cuts through the face, and immediately we see this lesion in the skin on the left cheek, and we see this lesion here again, and we see it extending along the infraorbital nerve, right there. And here's where it enters the pterygopalatine fossa, and it extends posteriorly through the foramen rotundum, and we see it extending along the V2 division, and finally into the cavernous sinus. Now, this patient went on to have a PET CT, and here are the images. We see this markedly FDG avid lesion in the left cheek involving the skin, and then we see this linear area of FDG uptake here. And this turned out to be a malignant melanoma on biopsy. All right, so to review this case, these are the structures that the malignant melanoma involved. So it started out in the infraorbital foramen, and then it went to the infraorbital canal, the pterygopalatine fossa, the foramen rotundum, and then finally the cavernous sinus. So you can see how this lesion extended posteriorly, and it kind of looked like this, basically, except that it did not involve the Gasserian ganglion. All right, so let's move on to our next case here. This is a 47-year-old woman presenting with right lower lip numbness. So here are a couple CT images. So take a moment and look at the image on your left and look for asymmetry between the right and left side. So you'll note that the masseter muscle on the right side is markedly atrophied compared to the left side. In addition to that, the lateral and medial pterygoid muscles are also a bit smaller on the right side. Now, these are the muscles of mastication, right? These three. There are actually four muscles of mastication. The fourth one is the temporalis. And you can see that on the right side, it's markedly atrophied compared to the left side. So we have involvement of all four muscles of mastication in this case. Now, what's common about these muscles is that they are innervated by the same nerve, the V3, which is the mandibular division of the trigeminal nerve. Now, V3 also innervates a few other muscles, and these are important to remember. We often don't think about these, but the interbelly of the digastric, the mylohyoid, the tensor veli palatini, and the tensor tympani are also innervated by V3. And we can, if you look closely, we can look for signs of atrophy of these muscles. So here are some more images of the same patient, the same CT scan. And if you look at the image on your right, you'll note that the interbelly of the digastric is atrophied on the right compared to the left. And on this image here, we have atrophy of the mylohyoid. The mylohyoid is a U-shaped muscle that forms the sling of the floor of the mouth. And then on the final image I've shown you here, we have a big mastoid effusion and a middle ear effusion. And these are indirect signs of dysfunction, of eustachian tube dysfunction due to tensor veli palatini atrophy, which is involved in eustachian tube function. So we've seen that in this case we have 7 muscles of innervated by V3 are atrophied. So now let's look up and see what could be causing this. So if you look at the skull base here, we see abnormality on the right side. But before looking at that, let's review some normal anatomy on the left side, the normal left side. So if you focus on the axial image, if you focus on that region, here's a blown out version of that, you'll see that we have two foramen. The more anterior and medial foramen is the foramen ovale, carrying V3, and the more posterior and lateral foramen is the foramen spinosum, which carries the middle meningeal artery, or the MMA. Now, this has been likened to a stiletto with the posterior little heel representing the foramen spinosum and the foramen ovale representing the footprint of the more front portion or anterior portion of the shoe. If we look at the axial, the coronal image here, this is the foramen ovale. It forms this little hole in the central skull base, and this, for Dr. Whipple, is also the chimney of the masticator space. So if the masticator space were a house, then the foramen ovale is the chimney, or arising from the roof of the masticator space that connects the masticator space to the intracranial compartment. So now if we look at the abnormal side, we can see that the chimney on the right side has been widened, and you can see that on the axial as well. We don't see a normal foramen spinosum or foramen ovale here. And what's important to note is that the margins of the bone here are smoothly remodeled, indicative of a benign, long-standing, indolent lesion, rather than destroyed or permeative, which would indicate a malignant lesion. So now let's look at the brain window, or the soft tissue window of this lesion. So you can see this lesion in the middle cranial fossa. You see it much better on the coronal and sagittal reconstructions here. It's fairly well circumscribed, and this lesion is going through and through the foramen ovale here. So let's examine this on an MRI now. So at the top here, I've shown you a cyst sequence, which is a highly T2 rated high-resolution sequence, and these two are post-contrast T1 images. So if you look at normal anatomy here, we have cranial nerve 5, which is sort of a fan-shaped nerve coming out from the pons. Meckel's cave is right here and here, and then foramen ovale is here. So this little hole here on the normal side, and it contains V3. So now if we look at the abnormal side, we have this large mass, T2 hyperintense mass, that begins in the cisternal segment of the fifth cranial nerve, and it extends through the Meckel's cave and through the foramen ovale, and it comes down into the masticator space. And this turned out to be a schwannoma as expected. So this was a schwannoma of the V3 division of the trigeminal nerve extending all the way back. So here's a cartoon sort of showing the involvement of this lesion. Started in the prepontine cistern, dived down into Meckel's cave, through the foramen ovale, and then into the masticator space. All right, now I'm going to teach you, this can be sometimes complicated for residents to memorize what are the branches of the trigeminal nerve. So I'm going to teach you a little mnemonic here. If you hold up your hands like this and hold out your index finger and your middle finger and your thumb and go like that, that's what I have shown here. Your wrist is cranial nerve 5. Your hand is the Gasserian ganglion, or the trigeminal ganglion. Your fingers are V1, V2, and V3, and that's the orientation that they travel in. Now, V1 and V2 go through the cavernous sinus, hence the blue area there, and V3 goes down into the masticator space. Now, we can get more fancy here and throw on a couple rings on my fingers there. These two rings are at the end of my fingers, and these rings represent foramen. So the supraorbital foramen is where V1 goes through, V2 goes through foramen rotundum, and V3 goes through foramen ovale. And another way to remember these three foramen is you think of a crowded space where there's standing room only. So standing is supraorbital fissure, room is for rotundum, and only is for ovale. So you can use this mnemonic not only for this, but also, if you're part of a gang, this can also be a gang sign. All right, so we'll move on to our next case here. So this is a 31-year-old man presenting with diplopia. Here's an axial CT. You'll note that the right side is abnormal, so we have complete opacification of the right mastoid, the right middle ear, as well as this region here, and this is the petrous bone. So we have opacification extending up to the petrous apex. Now let's look at this closely on a temporal bone CT. You'll note that on the right side, the petrous apex, the margins here of the bone are somewhat thinned out and in some cases destroyed. And so this is indicative of perhaps a more aggressive pathology. Now this patient presented with fever and elevated white count, and so this was presumed to be a case of otomastoiditis with apicitis, petrous apicitis. Here's the patient's MRI, T2 sequence and a T1 sequence. And on the T2 sequence, you can see, again, the complete fluid within the petrous apex and the mastoid. And on the contrast-enhanced study, we see enhancement of the petrous apex as well as the mastoids, indicative of active inflammation from infection. Now, how does this explain the patient's diplopia? He presented with double vision. Well, let's look at the anatomy of this region a bit closely. So this is the petrous bone. All right. So the petrous bone, at the apex of the petrous bone, we have a nerve that comes out and passes through the Dorello's canal, and this is the sixth cranial nerve, or the abducens nerve, and then it goes into the cavernous sinus. So when patients present with, otomastoiditis and complicated by petrous apicitis, the inflammation and infection can extend to involve Dorello's canal, and it can result in palsy of the sixth cranial nerve. Now, when that happens, in addition to a couple other things, abducens nerve palsy and retroorbital pain and otorrhea, that's called the Grad-Negro triad. And otorrhea occurs because of mastoiditis and drainage. Abducens nerve palsy occurs due to extension to the Dorello's canal, and retroorbital pain is because of involvement of the trigeminal nerve. So this was a case of abducens nerve palsy due to petrous apicitis. So Grad-Negro triad is kind of a sort of an Aunt Minnie to remember. Okay, so let's move on to our next case. This is a case, a 69-year-old woman who presented with a headache. This is a contrast-enhanced CT from superior to inferior, and we see this uniformly enhancing, well-circumscribed mass in the right CP angle, or the right cerebellopontine angle. And this mass appears to have a dural attachment here, suggesting that this may be a meningioma. This was in fact read as a meningioma, and this patient went on to have a couple other follow-up scans at yearly intervals, and this remained stable, so this was presumed to be a meningioma. Now the patient presented 5 years later, looking like this. So here this mass has increased in size. It's got central hypoattenuation, likely necrosis. It's causing edema in the cerebellum, and so it's got all these aggressive features now. If we look at this on MRI, this is a T1 post-contrast MRI, we can see that this mass again is heterogeneously enhancing. It's probably got some areas of necrosis within it. But what I want to point out with this case is there's something very interesting this mass is doing. On the image on the left, this mass is extending into Meckel's cave. You can see the normal Meckel's cave on the left here, and the Meckel's cave, as you know, houses the trigeminal ganglion, and so this is extending along the Meckel's cave. And on this image here, it's extending along the internal auditory canal. And finally, on the last image, it's extending into the jugular foramen. And you can recognize this as the jugular foramen because we have the jugular nerve. So if we look at this anatomically, it involves 3 different areas. It's extending to Meckel's cave, the IAC, and the jugular foramen. Now, here are a couple other sequences. This is a susceptibility rated, or a T2 star sequence showing hemorrhage within the mass, and a flare sequence showing edema. So again, indicating that this is an aggressive, likely malignant mass. So here's a question. Which of these is the least likely diagnosis in this case? Is it a meningioma? Is it a hemangiopericytoma, metastasis, or schwannoma? Well, on the initial imaging, we had thought that this was a meningioma based on its dural attachment. There are about 3% of meningiomas can be atypical or malignant, and they can, have this appearance potentially, the malignant meningiomas. Hemangiopericytomas are mimickers of meningiomas, and we throw them in the differential when we see a meningioma, what we think is a meningioma with aggressive features. So that's not the right answer here. Metastasis, as you know, can have any appearance really, and and certainly can have an aggressive appearance like this. So the right answer here is probably a schwannoma because this lesion is not dural based. Or sorry, this lesion is dural based and schwannomas are typically not dural based, as you see here. All right, so this patient went on to the OR for a resection. The day of surgery, she had a pre-op chest radiograph, shown here. And we see this large mass in the right chest. I went on to have a CT, and we see this mass along the right mediastinum. And we see another mass here, another, presumably a MET. PET CT showed avidity in the right CP angle mass, as well as the chest masses here. Now she went on to have resection of the intracranial mass. And this is what came back as the path, and I'll go through what we see here. On this low power view, we see whorls of mitotically inactive spindle cells representing meningioma. And then here we see small round blue cells representing small cell carcinoma. On this high power view, we see, again, meningioma cells, small round blue cells, and a sonoma body. And so this was a case of a metastatic lung cancer to a grade 1 meningioma, which is a very rare entity, and I think there are about 100 or so cases reported in the literature. All right, so far we've looked at the central skull base, we've looked at the foramen ovale, spinosum. So let's move on and look at some of the more posterior foramina of the skull base. So case 8, this is a 29-year-old woman with right facial asymmetry. Here are images from her non-contrast and post-contrast CT. It's kind of an eye test here, but you see this lesion in the right middle cranial, floor of the right middle cranial fossa, enhancing. I'm going to scroll through a couple CT images here. We see this lesion in the right middle cranial fossa, and it extends inferiorly. Here's the bone window. And the bone window is always important to look at because you want to see what this lesion is doing to the adjacent bone. Is it smoothly remodeling the bone, expanding the bone, or is it causing a permeative, destructive appearance? And in this case, we can see there is relatively smooth remodeling indicative of a benign lesion. Now here's the MRI. Now this had uniform enhancement. And here we see that the enhancement is actually extending into the right internal auditory canal through this little channel. And this is the image that I want you guys to sort of burn in your memory because this is sort of classic imaging appearance for this lesion involving the internal auditory canal and the middle cranial fossa. And here's just a coronal showing the portion of it in the petrous bone, in the middle cranial fossa, and in the internal auditory canal. On T2, this lesion was bright, somewhat heterogeneously bright. So what is the most likely diagnosis? Is this a cholesterol granuloma? Is this a meningioma? Could this be one of those schwannomas? Well, cholesterol granulomas typically occur in the petrous apex. This lesion is not quite in the petrous apex. Granulomas don't enhance. They're T1 bright to begin with. A meningioma would be unusual in this case because we did not see a dural tail. And this did not have a dural attachment as such. And neither was there calcification. All right, so this is presumably a schwannoma, given the osseous remodeling and the enhancement and the T2 appearance. But which one of these is it? We know that vestibular schwannomas are the most common of these. So one way to tease these out is to look at the vector of spread. Where is this lesion trying to go? So these three schwannomas, if we consider this area here, a vestibular schwannoma will spread in this direction. And here's an example of a vestibular schwannoma with that ice cream cone appearance. Trigeminal schwannomas will spread this way, sort of anteriorly and medially. And here's an example of one. Facial nerve schwannomas, on the other hand, will travel in this direction. And that was the case with our patient. The schwannoma extended in that direction along the course of the facial nerve. And so the diagnosis here was a facial nerve schwannoma. So let's take a minute here to look at some normal anatomy of the facial nerve, because this is a topic that often confuses residents. The first three segments are best seen on MR, and the later ones are best seen on CT. So on MRI, the pontine segment is actually within the pons. We don't see it on imaging, but this is where what it looks like. It travels posteriorly from the facial nuclei along the facial colliculus and then exits from here. The cisternal segment is within the cerebellopontine angle cistern. The intracanalicular segment is within the IAC. Now, if you were to cut this in this plane and look at it end on, this is what it would look like. You'd see 4 nerves, and these 4 nerves represented here. The anterior and superior nerve is the facial nerve, and you can remember that with the mnemonic 7 up and cope down for the cochlear nerve, which is anterior and inferior. And posteriorly, you have the superior division of the vestibular nerve and the inferior division of the vestibular nerve. Now, the remaining segments are best seen on CT, and I'm going to scroll through here and highlight the segments. So the labyrinthine segment is right here. And if you remember from our MR, this region was a little channel connecting the IAC and the middle cranial fossa enhancement. This is the geniculate segment here. From the geniculate segment arises the GSPN, or the greater superficial petrosal nerve, which goes to the lacrimal glands. Then we have the tympanic segment, which courses inferior to this lateral semicircular canal. And then finally, we have the mastoid segment within the mastoid bone. In the mastoid segment, there are 2 branches that come out from the mastoid segment, and those are the stapedial branch, which goes to the stapedius, and then finally the chorda tympani as well. And then finally, we have the parotid segment here. Now, if you weren't able to grasp the segments of the facial nerve, here's another way to remember your little mnemonic. If you take a little piece of paperclip and you open it up and you angle it such that they're 90 degrees to each other, you can imagine that the first branch or the first segment of that paperclip is your labyrinthine and canalicular segment. Then we have the geniculate, where it makes a 90-degree turn. Then we have the tympanic segment coursing underneath that lateral semicircular canal. And then finally the mastoid segment coursing, diving down. So those are the important segments to remember. Now, what about those sneaky little nerves that come out from the facial nerve and branch off? Well, this is how you remember them. So the greater superficial petrosal nerve arises from the geniculate segment, and it helps with tearing. So it goes to the lacrimal gland. The stapedial nerve comes out from the mastoid segment and helps with hearing. The chorda tympani comes out from the distal mastoid segment and goes to the anterior 2/3 of the tongue. And finally, we have 5 branches coming out of the parotid segment to innervate the muscles of facial expression. And here's a neat little mnemonic to use to remember. So tearing, hearing, taste, and face. Tearing, hearing, taste, and face. The facial branches, there are 5 branches that branch out and provide innervation to the muscles of facial expression. Now, if you go back to our case, these are some additional images on our 28-year-old female with facial asymmetry. On the top image, we can see that there's a muscle here that's very much atrophic compared to the other side. In addition, the buccinator muscle, also innervated by the facial nerve, is atrophic. And then finally, the platysma muscle lower down is also innervated by the facial nerve, and it's atrophic. So if you look closely, you can find some of these more subtle findings. All right, so let's move on to case 9. This was a 39-year-old woman with left shoulder weakness. So here are a couple CT images, and I've got some MR images at the same level. So here I want you to look for asymmetry again. Compare the right and left and see what looks a little bit off. So this muscle here on the left, this is the sternocleidomastoid muscle. You'll note on the left side it's markedly atrophic compared to that normal right side. And lower down, we have a muscle here that is the trapezius muscle, and that is also atrophic compared to the normal side. And what's common about these 2 muscles is that they're innervated by the same nerve, by the accessory nerve, or the 11th nerve. And this atrophy is indicative of denervation of that nerve. So let's look higher up and see what could be causing this denervation. So here we have a lesion, a calcified lesion, and it's located at the jugular foramen. If you can compare to the contralateral side, we have the jugular foramen here with the jugular vein, and we have this lesion here. And this lesion is extending all the way through and through the jugular foramen. If we look at it on a temporal bone CT and axial, starting from the top, this is the internal auditory canal. And then we start seeing this lesion. And here we see it going through that jugular foramen and coming out. And this is the hypoglossal canal right below the jugular foramen. All right. So I want to show you this image here. I got this from a cervical spine CT, and I reconstructed it here to show you some important anatomy. If you look at the occipital bones here, This should remind you of the double eagle flag of Albania. This is the head of the eagle, the neck of the eagle, and the beak of the eagle is right here. And we have two of them facing opposite to each other. Now, this lesion here, this was the lesion that we saw earlier. Calcified lesion is extending through and through the jugular foramen. So the jugular foramen is located above the head of the eagle, whereas the hypoglossal canal is located below the beak of the eagle. Okay? All right, so based on this, what is the most likely diagnosis for this jugular foramen mass? Is it a paraganglioma, schwannoma, or meningioma? These three, by the way, is the differential for a jugular foramen mass. These are the three most common things that occur in that location. Well, we know that this is calcified, so that points us in the direction of a meningioma. We don't see any aggressive changes in the adjacent bones. It's probably not a paraganglioma. Let's look at the MR here. So T1 post-contrast and T2, we see this enhancing mass. We see a dural tail here, and then this mass is hypointensive on T2, indicating calcification or hypercellularity. And so this turned out to be a jugular foramen meningioma resulting in 11th nerve denervation. So just to go over the anatomy again, this is what I showed you earlier with the double eagle sign. So imagine the cranial nerve 9, 10, and 11. They traverse the jugular foramen above the head of the eagle. Cranial nerve 12 is in the jugular foramen. And that's the eagle for you. Now, one way to think of lesions in these regions involving these two foramina is that a lesion like a schwannoma of the jugular foramen will cause the head of the eagle to be flattened, or will push down on the head of the eagle, whereas a lesion involving the hypoglossal canal will expand that neck of the eagle. So this is just a sort of a way to conceptualize what these lesions in different locations would do to the foramina. Let's look at a companion case quickly here. So this is a 39-year-old woman who presented with dysphonia, or difficulty with producing voice, and a history of breast cancer. So she underwent a PET CT to evaluate to see if she had any breast cancer metastases, and this was part of her workup of breast cancer. Now I want to draw your attention to the vocal cord on the right side. We can see increased FAG uptake there. Now, could that be a MET? Could that be a squamous cell carcinoma, a primary lesion of the vocal cord? Or could it possibly be hyperfunctioning of the right vocal cord with a paralyzed left vocal cord? Possible. If we're thinking about paralysis of the left vocal cord, that would be a cranial nerve 10 issue, a vagus nerve issue. We might as well look at other nerves that travel along with the vagus nerve, and that's 9 and 11. So 9 and 11 travel along with the 10th nerve in the jugular foramen. So are there any signs of 9 or 11 nerve atrophy here? And there we go. So the sternocleidomastoid on the left is atrophied compared to the right side. And now you see where I'm going with this. The trapezius muscle is also atrophied. So here we have signs of 10 and 11 atrophy. And when we look at the skull base, we see this FDG-avid lesion. Let's look at this on CT. Here's the lesion, and here is what it's doing to the adjacent bone. And again, we can see smooth remodeling of the bone, indicating a benign, indolent process. We don't see any calcification, and we don't see any aggressive features. Here's the coronal reformats. And you can see this lesion extends in this fashion above the head of the eagle, in a similar fashion to the jugular foramen meningioma we saw earlier. And on the bone window, you can see that this eagle has actually been decapitated. We don't see a head, we don't see a neck, it's just all gone. So it may be difficult to tease out if this lesion is primarily in the hypoglossal canal or the jugular foramen because of its large size. But given the pattern of denervation atrophy, we presume it's in the jugular foramen. Here's the MR. It's uniformly enhancing, it's low on T2, and here you can see that classic dumbbell appearance. It's got a portion in the cranial, inside the cranial compartment, and then outside here with a waist in the middle. And so this turned out to be a jugular foramen schwannoma with cranial nerve 10 and 11 denervation. All right, so the last case we're going to look at, a couple minutes here. This was a 72-year-old man presenting with TIA, transient ischemic attacks. So here's a bone window CT and a soft tissue window axial CT. Take a moment to look at the CT here. And so I have a question for you. Where is the abnormality? Is the foramen ovale abnormal? Is the carotid canal, the IEC, the jugular foramen, or the hypoglossal canal? Well, I haven't shown you the foramen ovale. We don't see it here. I've shown you a little bit of the foramen spinosum, but foramen ovale is not shown here. The carotid canal, you can see it there, and portion of it there, and that looks okay. The IECs I've not shown you on this image. We are much inferior to the internal auditory canal. How about the jugular foramen? You see the jugular veins here on both sides. They look asymmetric, but that's okay. That's normal. So the jugular foramen are normal too. How about the hypoglossal canal? So this is the hypoglossal canal here. And you can see on the right side it is enlarged compared to the left side. That's the normal size of the hypoglossal canal. On the right side it is enlarged. And furthermore, we see this weird calcification within the hypoglossal canal, perhaps extending a little bit out of it too. And so based on the appearance of the bone adjacent to it, you know, a smooth remodeled appearance, we're thinking, you know, this is probably a benign lesion involving the hypoglossal canal. It's got some calcification in it. This patient went on to have, before that, let me point out, again, the flag of Albania, the double eagle. This image isn't that great because I reformatted it, but you can see that hypoglossal canal on the right side expanded as compared to the left side. So this patient went on to get an MR to evaluate that abnormality, and we have T1 post-contrast, T2 flare sequences here. And let me draw your attention to this structure here. So this is in or adjacent to the hypoglossal canal. You can see it's somewhat linear, and it's got T1 hyperintensity, intrinsic. It's also enhancing, and it's dark on T2 and flare. So this actually looks like a vessel that has flow within it, and it's enhancing, and it's got a flow void on T2. So what kind of vessel would go through the hypoglossal canal? Well, let's look at this patient's MRA. I'm going to scroll through the sequence here. So we have right carotid, right vert, left vert. This is the right carotid bifurcation, and so it's branching to the ICA and the ECA. And as we follow the right carotid up, we see that it's actually got a second bifurcation, if you will, with this abnormal artery coming out posteriorly and coursing through the hypoglossal canal, right there, and it joins the basilar artery right there. So this was a case of a persistent hypoglossal artery, a fetal, which is one of the fetal carotid basilar anastomoses that you guys need to be aware of, in addition to the persistent trigeminal artery and otic artery and proatlanto, the PIA artery. So not all lesions involving the foramen are meningiomas or schwannomas. Sometimes you can have weird things like this. So these were all the cases. Thank you for your attention.